Before
Thank
Sridevi
you.
starts, sorry, can everybody please switch the video on? This is the only occasion, at least virtually, let us see each other's face and give me a smile each, everybody, after switching the video on. Sri, over to you.
So over to Dr. Audit. I'm just.
This is a quick bouncing ball this morning, this afternoon, evening. Welcome everybody. So good to see you. As Dr. Raj said, please put your videos on because then we can all get to know each other much better. It's such a pleasure to see you all again for this third session. Welcome. Thank you very much to Dr. Raj for stepping into this session on because Dr. David Brumley was unable to do so today. We really appreciate you stepping in at relatively short notice and couldn't ask for a better presenter on this topic. I think, I don't really think I need to introduce you, Dr. Raj. Do I need to introduce you?
No, I don't think so.
I'd like to sing your praises, but
wait a minute. Penny is the only name that I am unfamiliar with.
Penny.
Who is Penny?
Can you turn there you are. Okay. You can't get away with it.
Hello,
Sorry,
Penny.
a light right behind me. Hello,
Hi.
I'm Penny. I'm a pharmacist from Perth, Western Australia.
Okay, Penny. Welcome to the program.
But Penny, more about why you're part of this program.
Why am I part of this program? So I've been visiting Silchar, Assam. I've had 3 visits there as part of the program. And unfortunately not been able to go this year.
She's too modest, you see. She's been a great member of that team too, Silchar, hasn't she, Iqbal? Anyway, Dr. Raj, you were about to,
okay.
Don't start your presentation just yet. Were you going to say something else more general?
No. I was only going to say that it's so good to see some friends after a long time. I see Iqbal, I see Ali. I don't see many others. Mostly others are. Oh, Damayanti Singh. And Damayanti is from where?
Where's Damayanti? Is she?
Damayanti, can you
Singh?
unmute and speak even if you can't put your video on? Damayanti, where are you from? Sorry, come again.
Can you write it in the chat, Damayanti? Because it's not coming through very clearly. We'd love to know where you're from. Can you put it in the chat?
Sure.
Thank you. So shall I start with a little introduction then, Dr. Raj? Are you ready to?
Yeah, not for me, not introduction for me because they all know me, but introduction to the subject by all means, please.
I did want to tell them that you, in addition to being the director of APLI in India and a great friend, you're also a wonderful Chapati making teacher, being a student of Chapati making of yours. So he is a man of many talents. But as you know, this topic of opioid availability came up in the learning needs assessment that we did last year, as many of you participated in, and we really thought it would be great to kind of hear some of your real world experiences in being able to obtain and prescribe and monitor opioids in your patient group in your particular setting and learn from each other. So over to you, Dr. Raj, to sort of give us an overview of where things are at nationally.
Thanks, Odette. Sridevi, my time starts only now. Friends from India, please note that Odette comes from a very confusing country where they have too many choices. You ask for a cup of tea and they will ask what tea. For us, tea is tea. For them, it is about 73 different flavors and varieties. Same thing about opioids. You want to start a step 3 opioid, they have many choices. Here, most of the time, it's just not available, or if it is usually limited to an extreme maximum of 3. That's it. 2 oral and 1 transdermal. That's all that we have. So what am I saying? Things are very simple. You don't have to learn confusing pharmacology between so many things. But the problem is, we don't have the medicines most of the time. I don't know if you have seen the minimum standards that IAPC has decided on. It is there on the, now it's Pallium India also is there. Indian Association's more updated minimum standards are there on the website. So one of the basic criteria is that you should have uninterrupted access to oral morphine. Another one is that you should have proper documentation. These are things that are necessary, but is it your job? Sometimes the question has come up. Well, it's up to the management, the administration of the hospital, or up to the pharmacy to procure it. You're a doctor. What do you have to do about it? And these are some of the issues that we'll talk about. We will start with a question to you. Sri, will you explain the poll if you are ready with it?
I think Sripriya, it's for you, not.
Yes.
It is confusing,
But-
like whether it is Dr. Sri or no.
No, confusion there also. Multiple choices, yes.
Okay. So, Tim, we are about to launch a poll wherein there would be actually 2 polls. Once we launch the poll, you'll be getting prompt in your screens. So you just have to choose the appropriate answer, the response which feel the most appropriate to you. And once all the questions are finished, you just have to submit it. Sir, are we good to go with the poll? Yes.
Yes,
poll
please. Sri, if we have only about 11 participants, so that's fine. We can move on to the second poll.
Okay, sir. Launching the second poll.
Okay, right. Thanks. So let us have an afterlife for the Hamrahi course, and we'll decide with Odate's permission that we would set it as a goal 3 months from now. That is mid-May. All the institutions that do not now have oral morphine should have oral morphine. I'm not making a particular fuss about the second question in RMI, because in some states that may not be so easy. For that, we'll set a longer timeline. But in 3 months, let us hope that everybody will have it. I am saying that because I strongly believe that our duty. Oh, why my unable to stop the pole coming. Remember, our goal is this. If we are to mitigate suffering, if we are going to fulfill our primary duty as a healthcare provider, as defined by the bioethics unit of Indian Council of Medical Research, because we do not have a law covering this. If we are to mitigate suffering, there exists no exception to this, then we will have to make it available. And there could be resistance from the institution. It's up to us to make sure that we make it available.
Sir,
And,
sir, sorry. Would you want to make it full screen?
sorry.
Right.
And let us remember this also. We said we'll ensure access to oral morphine. That's not enough. We have to follow the principle of balance. That's accepting our dual responsibility. One, we need to prevent, well, abuse is not a fashionable term now. It is non-medical or inappropriate use of opioids, non-medical or inappropriate use of opioids. And we need to make opioids available to those in pain. Both are your responsibilities. Once we all work together to make sure that your institution is an armory and that you have uninterrupted supply of oral morphine there, and maybe other opioids and other formulations also, we will accept this responsibility. We will not take it lightly. If 25 tablets suddenly vanish, not to be located, we will investigate. We'll find out why it went, and we'll make sure that it doesn't happen again. So we will, if you are saying, yes, we have oral morphine, but in between last year, for 2 months, we did not have it, or for 1 week, we did not have it. We'll find out what are the barriers and take remedial measures. Because Ali, Iqbal, and others, you are pioneers who have to establish that system and tradition to be followed over the next century in your hospital, because you are the pioneer who got it started. And I think we have to make sure that this responsibility is accepted. And if some people come to you and get trained and go back, you will make sure that Ali does make sure this. He is not working only in his island. He works and makes sure that people in pain in other islands also have pain relief. Other islands in his union territory have access. That's what we should be doing. The issue is fairly easy now, because in 2014, this complicated law, Sheba fondly keeps it in her library. So that's her weekly exercise, is to lift the NDPS rules thrice. It's weightlifting. That complicated and heavy thing, it got amended after 19 years of efforts by palliative care workers in 2014. So what we'll do is, I shouldn't scare you with this picture. That's amended, gone. But what is the simple current regulation? Let us try to get some clarity. In the first panel, you have the requirements in the old rules. You needed a possession license. You needed import permit. This is the terminology from the days of colonial rule. The import is not from outside the country. The import is for transfer across states. The manufacturer in Mumbai will have to then get an export permit to get it across to you. And then in many states, they need a transport permit to move it from the capital to your town. And for all this, you had to have licensing from multiple agencies. Penny, is your head spinning already? Because for each of these, I had to go to the drug controller several times, local excise office, excise secretary's office in Trivandrum, and then to the drug controller's office again. And sometimes they say, no, the paper is missing and you have to start all over again. And then you have to get the import permit, order the medicine, and then what you find is they may not have the medicine. It may be delayed by a week. When it comes, the import permit has expired validity. You can't open it. You had to send it back. And these, all the problems are for us solved with the amendment of 2014. Individual states no longer have different rules. At one time, every state could make its own rules. Now the central government says, this is the new rule. Every state will have to follow it. And that's a decision by the parliament. It's law. You cannot shift it except by another act of parliament. The new amendment created a new class of medicines called essential narcotic drugs. You should know that in this context, drugs again is not a preferred name. We tend to prefer to call it medicines nowadays because drugs are stigmatizing. Similarly, narcotic is an unscientific word. We are talking about opioids. Nevertheless, this is legal terminology in the law. So at least for legal purposes, we will have to follow them. Recognized medical institutions approved by the state drug controller do not need these, like any of these licenses. If you want to store an essential narcotic drugs and dispense it, you get a certificate of RMI from the drug controller, no other agency involved, single window. Drug controller says, okay, your institution is an RMI, and then all that you need to do is to order whatever quantity you want from a manufacturer. I'll stop there to take any questions.
So good evening, Dr.
Hi.
Koshi.
Yes, Dr. Koshi from?
Jamshedpur, sir.
Yes, Dr. Koshi. Hi, hello. Oh my God. 12 years. Yes, Dr. Koshi, what's your question?
Sir, so my question is this: recognized medical institution, what's the definition like? Recognized for?
Recognized for stocking and dispensing essential narcotic drugs.
So, no, there is no classification now as indoor and outdoor.
No. If you are an RMI, you can use the ENDs, essential narcotic drugs or opioids, in your theater, operation theater, in your outpatient, inpatient ward, home visits. You can take it home to patients. No limitations.
Okay, sir, because we had oral morphine, we had to stop it because I stopped it because it was expiring. Only it was allowed for indoor.
I know that your state had that problem. We tried to resolve it. Koshi, if we work together, we can resolve it. Now, this Dr. Koshi Varghese has brought up this problem. This is the law. This is the law of the land. But drug controllers do not know this. Hospital officials do not know this. Excise do not know that they are no longer involved. So, in many states, the wrong practices continue. So, Koshi, there is absolutely no doubt about it. If you have been approved as an RMI, when they say you can use it only indoor, they are making a mistake. We do not want them to lose face. Gently, we must point out that this is not possible. This is the law. Sorry. In the state of Uttarakhand, anybody from Uttarakhand here? Rajendra, this happened 2 years back, you know this. In Uttarakhand, the drug controller's office, the drug controller had agreed. But somebody in the office sent a letter. Okay, if you want the RMI status, tell me what is your plinth area. Send me a floor plan of your institution. And with the permission of the institution, I send a letter from our WHO collaborating center by registered post to the drugs controller saying this is against the law of the land, must be a misunderstanding. Please correct it. And they corrected it. It may not happen so. Every state may not be responsive like that, but we should try. We'll keep trying, Dr. Koshi Varghese. This is something that Sri Priya has taken a note of. If your institution also approves, and we work together to make sure that this is rectified.
Thank you, sir.
Any other question?
May I ask a question?
Yes, Sudesh.
I wonder how common that situation still is. How often you encounter a similar problem across India?
I wish I could say that it was rare, but it's very much otherwise.
Okay.
New complications are brought in and the problems keep cropping up. Many states do not follow rules. And in a couple of border states where the problem of inappropriate use is high,
Yeah.
and the drug controller will say, we don't follow those rules. Nothing doing. Even that happens. And sometimes we have to keep on working, not fighting. I won't use the word fight.
Sure.
It's very difficult to fight with the officials and win, but we'll keep on trying. And well, when we have tried hard, we have never lost.
And do you have, maybe you'll talk about this, so please let me know, but do you have good model states around India that you can, does that help to, or not really? Is it more each one does their own situation?
As far as opioid access is concerned, for a long time, Kerala was the model. But here, in this matter, even in Kerala, there is one problem, which I will come to in a moment, which is not a big issue and we have let it go at the moment, but because the drug controller has a point, but we will sort it out only after a revision of the rules which have to follow. So Sridevi, I get extra time for the question answers. So one term, everybody, please note, Act is the law, NDPS Act. Rules are executive orders. They are not the same. Just note this one difference. Rules follow the act. The parliament enacts a law and then the bureaucracy create the rules. Rules are the ways in which the law will be implemented. Department of Revenue, which is still handling this matter in Government of India, has created a list of essential narcotic drugs. And among them, morphine, fentanyl, and methadone are 3 opioids that are relevant to us. Others are not. Please note, unfortunately, pethidine has not been included. So RMI, with your RMI certificate, you can't procure pethidine. But any formulation, injection, oral, syrup, transdermal, anything of these 3 medicines, if you are an RMI, you can just order and stock and dispense. Got it? Questions? Remember, fortunately, these rules are easy to change. I mean, comparatively, the law needed the parliament. That's why it took 19 years. But rules, if we have the muscle, we can work with the government of India. And if they want, they can change the rules in 1 week. So according to the NDPS rules, here is the basic minimum requirement for an institution to be an RMI. You need a doctor who is MBBS or BDS as in charge. That person must be in charge of the RMI. In my institution, I am the doctor in charge. Our pharmacist handles it, doctors handle it, nurses handle it at home visits. The stock register is kept by the pharmacist. I check it and countersign it. To be named a doctor, the doctor should have had training in pain management. What length of training? That's not defined by the rules. Government of India doesn't say what is appropriate training. But so it will be today left to the drugs controller to decide whether you are this training is enough or not. In Kerala, in 2020, the drugs control after the pandemic came and physical courses stopped, Kerala drug controller issued an order approving of online training as adequate for approval as an RMI. So if you have gone through in Kerala today, our FCPM, that's enough. Virtual foundation course today is enough, adequate training. The drug controller has not said the FCPM, they have just approved of online training. Okay. But that's only Kerala. You may find that in Chhattisgarh or Jharkhand, they may say nothing doing. Go and get a letter from there or here or something. Those are risks of the game. This is good if the Ministry of Health had defined it, but it has not been done yet. There is more to it. The rules also say that government hospitals do not even have to get a license. They are deemed to be RMIs, but they have to ensure all documentation. They have to inform the drug controller who is the doctor with training. And every year, the consumption data have to be provided to the drugs controller. I'll tell you, I'll show you later how you find the forms, etc. Every year on an appointed day, you have to send the consumption data. Over the last 1 year, we got so much, we used so much. Questions? This is how Sheba established a system long back. We keep the stock like this. I'm not saying that the rules say exactly this kind of thing is to be done. Just showing what we do. All the entries, receipts are written in red. So much came, received on such and such a day from such and such a company, batch number, date of manufacture, date of expiry, quantity. We keep separate registers for 10 milligram, 20 milligram, 50 milligram, injection, all separate registers is our practice. It does not have to be that, but we find that simple and convenient. Separate register for each strength and each formulation. So this is 10 milligrams. On the first of the that day 19th of the month, we gave to this person the name and his register number, issued 35 tablets, so that we had so much of closing stock. Every day you write how many tablets have been issued to each different patient. This number makes sure that we have the file with us. With this number, they will track the file so that we have the record of how much was prescribed, quantity dispensed, balance in stock. After every dispensation, if there is such a word, you write down how much of tablet is left. This is what we do. I, as the doctor in charge, countersign at the last column. Now, this presentation will be shared with you all. Sri Priya will make sure that you get it. And you will find that here, you go to this link, you will find all the forms that need to be filled. Like when you start, you will need to fill up a form in which you will have to give your name, address, institution's address, etc. Those will have to be filled. And this document for best practices was created by our colleague Dr. Nandini Vallat. I think it's an excellent document, laying out what are the principles to be followed, how do you keep the stock, etc., etc. And once approval as RMI is obtained, you place an order with the supplier. So when you apply for this, the drug controller is obliged to respond within 2 months. He or she will have to say, yes, you are an RMI, here is the order. There is a particular form which he'll fill up and send you, which you keep. Or he or she will say, sorry, it is not approved because such and such a reason. And then we'll have to see if that reason is reasonable, and then we'll have to work together. Then you contact us. Hey, what do we do? And with what our experience in the past, we'll work with you to make sure that the problem is rectified. One thing I want to tell you, very important. If you do not have it in your institution, start a separate file, one file only for your correspondence with the drug controller on this matter. All the, whatever you write, hey, you must keep a copy. Every letter must be sent by registered post. My office is only about 2 kilometers from the drug controller's office. But if there is a document like this, I will not take it to him. I will send it by registered post so that I have a document. The document is kept. It was kept or sent on such and such a day, so that the onus is on them. They can't say, no, we did not get it. So this is the process, the procedure. Fill up the forms, keep the stock properly, and when you have the RMI certificate, place an order with the supplier in the appropriate form. Another form will have to be filled up. Place the order, send it by registered post. All documentation has to be ensured, including the register in which the opioid is received and used. I'll stop there. I'm sure there must be many questions. If necessary, I'll go back to the presentation. But can we continue with the questions? So to those institutions which said they do not have morphine, Let us initiate the process tomorrow. Immediately, let us find out what is the problem, or write to us, this is the problem. And sometimes it's a new superintendent coming in. Sometimes it's a new pharmacist coming in. No, no, I can't do this. I don't want to take this risk. These all issues come up. Sometimes it's a paper getting lost. Whatever that is, we will talk about it and initiate the appropriate procedure. So, Sri Priya, we have a deadline of 15th of May, by which time every institution listed here among the 11 will have access to essential narcotic drugs, that is essential opioids of step 3 of the ladder. Dr. Koshi, I haven't seen you for a century. Just take your mask off for a second. Hi.
Sir,
Hello there.
good evening, sir.
Okay. Hey.
Thank you, sir. So I have all the injectables with me.
Good.
Fentanyl, morphine, pethidine, 14, all of them are there. Tablet also I had, then they expired because OPD prescription was not allowed. Now MTMH has a full-fledged palliative care unit. They are also having this dilemma of OPD prescription. Therefore, I asked this question for both. MTMH now has grown into a full-fledged cancer hospital with a proper palliative care unit.
Dr. Koshi, let us address this issue. We would have addressed it long back, but at that time, we were told, no, wait a minute, this is okay for us. But this is unfair. This is cruel to patients. Actually, MTMH was admitting patients just to give them a supply of morphine in paper, admitting now, discharging them after 2 hours. This is unfair. This is irregular and against the law. So what we'll have to, your institution will have to accept. Okay, the problem is they may say, no, we don't want to get into all this problem with the drugs controller. We are having a good relationship. Let us maintain it. Let us maintain the good relationship, but let us also be fair to the patients. We don't want to fight with them. We'll gently point out, this is the problem. This is something we must overcome. Unfortunately, you are not in the capital of the state, which means that things are a little tricky for you in terms of follow-up. Let us do it all by correspondence.
I wonder if I could ask about the role of the pharmacist in India and whether they are at all involved in some of the regulatory side, keeping track of medications. I guess it's another area here where we're lucky. In addition to all our brands of tea, we also have pharmacists who take care of so much of the paperwork and documentation. And it does seem very onerous on the medical practitioner or the nursing practitioner to have to keep all these records.
Thank you. Very valid question. But Kerala, I don't know the latest number, but has about 175 RMIs. They all would not have a pharmacist. Many of them are small units, just a home visit program, operating in a village, 2-room establishment, 1 room being the one strong room. They have a full-time nurse and a doctor who comes once a week and no other staff. This is the reality.
But I can understand that in that's probably small number, you're not keeping a lot of records either. You've got a smaller clinical load. But what about in the bigger centers?
I'm just mentioning the bringing it to context today with the legal situation also, just to make sure that everybody understands this. So those who are working in small establishments, I don't think there are any in this group. The rules permitted in 1996, 7 or something, the Drugs Controller General of India issued an order under drugs and cosmetic rules that palliative care centers are exempted from the need to have a pharmacist to stock and dispense opioids. So this happened such a long time back. So even without a pharmacist, we can function. But the unfortunate thing, Odette, is that the way it was created and tradition came in there because every institution does not have a pharmacist. They wanted to bring in uniformity and they made a doctor responsible. This has become a problem. It's a big problem. Many institutions have doctors with training, but they don't want to take the responsibility. They will say, why should I get into criminal case if there's a problem? So this is a problem I acknowledge. Having said that, the practice is, okay, I am responsible. I will have to be responsible till the rules are changed. The law doesn't have to be changed. If the rules are changed, that will be okay. But we will have to make sure that for the time being, the doctor will have to be responsible. But okay, our pharmacist does it. She does all the work. She keeps track of everything. We have 7 home visit teams going out every day. Each nurse is taking a stock of opioids with them. They dispense it. They bring it all back in the evening, and all the entries into the register are made. That work continues. So, Odette, I hear what you are saying. This is a problem that we want solved for the future. But at the moment, pharmacists can do it, but the doctor will have to take responsibility.
I'm just watching the time a little bit, Dr. Raj. Is there further presentation you'd like to
No,
continue, or
no, I am done. Sridevi
you-
had given me a very clear instruction to stop in 20 minutes. And I am hers obediently.
No, it's good. We're happy to have the discussion.
No.
I'm sure there's so many questions. Dr.
Doctor-
Kandawal, will you?
Yeah, Dr. Odette, I have a just what you asked, the same, I'm facing problem. Actually, I am at 2 places. One is a medical college, which is, first let me introduce Dr. Rajagopal. I am Dr. Khandelwal from Patna, Bihar. And I am working at 2 places. One is a medical college, private medical college, which is 150 kilometers from capital Patna. Sasaram is the place. Narayan Medical College, which is a postgraduate institution in many departments, and more than 1,000 medical students and doctors, more than thousands are all the time present here. And other is a corporate hospital in Patna. Patna, I will leave it because problem is less there. The problem of awareness among the doctors to use such medicines, as you rightly said, not drugs, but these medicines, they are not aware or less inclined for prescription. That is a separate issue. But in medical college here, I just inquired today also, I'm there only, the license is not given by the Bihar government. We probably didn't know all these rules what you just described. And I talked to pharmacist, he said that we are not permitted to keep, though it is a medical college, postgraduate, many departments, but they are not given permission. And moreover, another problem is the pharmacist runs the medicine shop. No doctor is directly linked. So why any doctor will take charge of the whole the medicinal part, whereas not 1, 2, 3 pharmacists are working round the clock for that medicine shop. So what Dr. Odette said is the problem of doctors rather than pharmacists managing that. That remains a problem here. So both issues, first the license, and second, who will keep the record of all those medicines? A pharmacist is a better choice for us in Narayan Medical College. Of course, otherwise a doctor has to be And which doctor will take responsibility? I'm not sure, unless because there is no palliative department as such separate here. Of course, other medicine, anesthesia, everything is well developed with post-graduation, but there is no palliative department. There is a tumor board. I am in chairman of tumor board, and tomorrow I will discuss this issue and will share some of the knowledge that I just got from Dr. Rajagopal. Thank you.
Dr. Khandelwal, thank you very much. You have brought up an area that I had not actually covered. I was dealing only with the institution getting the RMI status. There is another way. Most states do not have it. By the rules, individual drug controller can permit individual pharmacies to stock and dispense opioids. It happens in some states. Very clearly, as you say, in Bihar, it's happening. It's happening in Delhi. It's happening in Rajasthan. But the drug controller usually authorizes only a limit, 1 or 2 pharmacies in every city to stock and dispense it. If that is done, you are not involved. You just give a double prescription and the pharmacy dispenses it. If you are writing your prescription in the proper way. So that is a possibility. But in majority of states, because of the possibility of abuse, the drug controllers do not permit private pharmacies to stock and dispense it. They can if they want to. Secondly, Dr. Khandelwal, yes, I see the problem there. So in medical college, you do not stock morphine, right? Or ENDs, no. So I see that Rajendra is here and Sunanda is here, right? Who has the jurisdiction? Who works in Bihar? Sunanda. Sorry,
बिहार में कर रहा हूँ सर.
Rajendra.
डॉक्टर खंडेलवाल जी से मैंने बातचीत भी की है पहले.
So,
मैं उनसे
so Dr. Khandelwal, if you would initiate, I mean, if you would like, we can initiate these steps, like what is the current status about each of these problems and how we will move forward. One thing, let us make sure that in that medical college as well as in your other institution, we should have opioids. But without any significant risk to yourself, you have to make that happen. We will have to do it according to the current rules. The only alternative is to get a pharmacy to stock it. And most pharmacies do not want to do it because of the paperwork involved. Drug controller may not want to permit. These are all real problems. And in some states like Bihar, the problems are more complicated because of the previous legal issues, etc. But we'll address that individually. So for the others also, individual states may have problems of their own, which we will have to deal with one by one.
Thank you. And thank you, Dr. Khandelwal, for raising that. I think every question that comes up, I think, resonates with many people on the call. So it's great. And it's a good way to segue, and if I could, Dr. Raj, segue into the next phase of the session, where we're going to hear from 3 of the colleagues in India working in 3 different areas of India. And the first person actually is Dr. Rita Rani, who's working at Mahavir Cancer Center in Patna also. So it would be great to hear what your experience has been in tackling this issue of opioid availability. Dr. Rita, over to you. Thank you.
Hello. Good afternoon from India, Patna. Good afternoon, everyone. Am I audible?
Yes,
Rita,
you
can I
are.
interrupt?
There's
Dr.
a little
Rita,
bit of...
there is an echo when you speak, and that's
Okay.
happening possibly because in the room in which you are in, possibly
Yes,
2 people have connected. If there are 2 connections,
yes,
that echo
actually,
happens.
yeah,
So
I'll just
you will have to switch
check.
off one of them and just use one connection.
Hello, sir. Hello.
Yeah, yeah,
Now
yeah.
That's
it's
Now,
not.
great. That's
Good
better.
afternoon, sir. Good afternoon, Rajagopal sir. Good afternoon, Dr. Audit. It's nice to see you. And before I start my presentation, already quite a lot has been discussed about Bihar. And I am supposed to give you an idea about the opioid issues availability in Bihar. That is what I had understood. So I have made a PPT and I'm just going to share it. Actually, I was struggling with my system. So I
Can you just give us one moment because we found two Rita Rani profiles. I believe the other profile was my co-host. Just give us one moment.
yeah,
Vaiko,
sure.
do I have your support here?
Actually, excuse me.
Yes, ma'am, it's supposed.
Yes, now you can share. Sorry for that interruption.
Okay. I'm unable to share.
Sri Priya, have you given sharing rights to?
Yes,
Yeah,
yes.
it's a different screen, I think. Somebody else's screen.
Yeah. Actually, one I have entered through my mobile.
Yes, sir.
If a pharmacist is
Oh,
not able to submit the annual report, what are the punishments or what are the consequences? Suppose the record keeping is not found good or he is unable to submit annually, what are the consequences?
What usually happens is that they will cancel your RMI certificate. They will ask you to return the medicine to the manufacturer or to another RMI. They will cancel it.
Any criminal case or any financial punishment?
Ordinarily, no. But what is likely to happen is, if there is an abuse issue, you are not supposed to have any stock which is unaccounted. It is a crime in our country to be in possession of opioid medicine. These are the essential narcotic drugs without authorization. So suppose your stock register says you have only 3 grams, and actually the drug inspector finds that you have 28 grams, that's a crime. So whether it's a pharmacy or a hospital, we have to be accountable. There is no doubt about it. Yes, a criminal case is a possibility. It happened in Punjab where 2 doctors were arrested. But ordinarily, there will be an investigation and they will, what happened in Punjab was an exception where there is a personal animosity and they use that occasion. But ordinarily, they will find out what's the problem. And if they find, okay, here is a pharmacist or a doctor or somebody was actually selling medicines on the streets, naturally there will be serious consequences. Dr. Koshi raised hands.
Yes,
All
Dr. Koshi. Yes, I was just going to mention that. Dr. Koshi?
This is, so thank you, madam. Thank you, sir. This is a related question which had come up in the earlier this thing. Is, does the patient have to keep a track of the consumption of the
Dr. Koshi, you've gone on to mute there. Sorry.
Yeah. Am I audible?
Yes.
Does the patient have to keep a consumption pattern of the morphine, or does it stop if I have prescribed it as far as the legal thing is concerned in India? This is my question to Dr. Rajagopal, sir.
Koshi, it stops there. Your legal responsibility stops once you have given the medicine to the patient. If the patient does not use it, and if it is there, that's no issue legally. But if the person sells it outside, that is a crime that committed by the person, not by you. If the person doesn't use it and return to you, okay, here are the tablets, or the patient died, the family brings back the tablet, you have to enter it into stock. Legally, that's the procedure. You receive it, enter it in stock, and that you cannot keep unauthorized stock.
Thank you, sir. And in my register, I just need to give the total numbers only, na, sir? Or I need not give the dosage of the individual patient.
No,
only I need to say
Dr.
that I have
Koshi,
dispensed X amount of drug. That's all. Na?
Dr. Koshi, as I said, we will have to keep that in your file or somewhere. Your case sheet in the hospital or a duplicate prescription will have to be kept showing how much you have given. I'm sorry I did not make it clear.
Okay.
One
and
prescription.
Can I, sorry to interrupt, but I'm very conscious we've got 3 speakers who need to give their talk in the next 30 minutes. So I wonder if that conversation could continue perhaps after.
Offline, I'll certainly take the question later. Odette,
Thank
for
you.
everybody's knowledge, let me just clarify that the institution keeps one copy of the prescription.
Yep. Thank you. Okay, over to you, Dr. Rita. Let's hope internet's kinder this time. We can't hear you if you're talking.
You have to log in with your mic. Your mic is not enabled, so till that time it is not enabled, you will not be audible for us.
It looks like she's got her sound on.
Hello.
Okay,
am I
good.
audible?
Yes, great.
Yeah, am I audible?
Yes, yes.
Okay, so I hello. So
oh. Bad luck.
Where is my screen?
Rita, would you mind if I ask Dr. Ali to present while you're getting organized, trying to get that sorted? I'm sorry you're having so much trouble. Dr. Ali, do you want to share any slides? Okay.
Yes, can you see me?
Yeah.
Okay.
Good.
Can you hear me?
Yes, Ali.
It will be a quick and short presentation. And I'm grateful to Dr. M. Rajagopal sir, who is all behind for us all these years to support us as an RMI to get the license of RMI and renewal process everywhere. Dr. M. Rajagopal sir is a great support and always a guide to us. I thank you. I'm very grateful to you, sir. And I'm working with Tamil Charitable Organization, which has got a status of RMI. We have been enjoying the privilege of recognized medical institutions since 2013, and it was approved by Drug Control State, Kerala State of India. And we have been allotted a quantity per year of morphine. We have procured only morphine, 20 grams. And we're procuring this morphine from Lisi Hospital of Ernakulam District, Kerala State, India. And this procured medicine is being transported to Kavaratti Island. It gets stored at Kavaratti Island. And according to the need, it is distributed to, the morphine is distributed to patients in other island after the certification of medical officer in charges of concerned hospitals in that island, so that there will be a proper documentation and proper reference of the patient. And this is the chart, body chart, pain score, and what we are planning for pain medications, analgesic ladder in our case sheet. The pain score is recorded, and the prescription of what step 1, step 2, step 3, and all combined step. What step we have taken, it is all recorded in the case sheet of patient, which is being kept at the Kavaratti, the main headquarters of RMI. And the morphine is prescribed to patients with necessary instructions of morphine use, the timings, the use of laxatives, use of antiemetics, etc. That are being prescribed with necessary instructions. And the record is being kept in the format run by Drugs Control State. This is our format that being recorded here at Kavaratti Island. And the issues are, being an union territory of Lakshadweep, we do not have a licensing authority or drugs controller for a morphine supply. Lakshadweep don't have a separate licensing authority or drugs controller in our state. So we have to approach Kerala state for the renewal, dispersal, or distribution of the essential narcotic drugs. And the transportation is always an issue. There is a delay in supplying morphine, and there is a sometimes it may interrupt the supply of morphine to the patients. Interruption of the supply from the Kerala state to Kavaratti Island and from the Kavaratti to other islands because of transportation, because of bad weather conditions, monsoon, etc. So the transportation is always an issue, and I think we have to send the this thing, renew documents, everything. From Kavaratti Island to the Trivandrum city. So there is a huge delay of processing and this documents and the renewal of the RMA. So I think there must be some online system to apply and renew the license so that we can apply online and we can get the RMA certificate get downloaded from in the Kavaratti Island. So that's our issues. Thank you so much.
Thank you, Dr. Ali. Dr. Raj, any comments you'd like to make before we move on?
No, I mean, the population in Lakshadweep, it's a archipelago of many islands. It is a marginalized population, really, because of the seclusion and the need for the issues regarding to transport, which also will be related to the weather and the political turmoil from time to time. So I hear what you are saying, Ali. The one thing that we must do is to make sure that if we keep always a supply for 3 months in advance, you will have to keep it for 9 months. That's the only solution I can think of for the time being, but let us talk more about it. See if any other possibility opens up. The drugs controller is a nice person in Kerala now.
Yes.
So maybe we
Yes.
can see if we can help in any other way.
Thanks.
Thank you. Iqbal, would you like to talk about the situation in Silchar, Assam?
Dr. Iqbal, you are muted. We can't hear you.
Okay. Good afternoon, everybody. I'm very much happy to be a part of this today's online session, and seeing Rajagopal sir after so long time is really a wonderful thing. Rajagopal sir, I underwent the first test of the palliative care with Rajagopal sir way back in 2009, and still I am on this path by the grace of Almighty. And it's an honor to be associated with this wonderful person. And whenever I hear Rajagopal sir again and again, it's really a pleasure. I want to hear him continuously. Each and every words are just like gems. And this is very, very. I'm grateful that I'm a part of this today's program. Thank you, the Hamrahi team, for giving me this opportunity to say something about our place. And I'm a palliative care physician. I have underwent training in Rajagopal sir way back in 2009. Then I joined the Department of Pain and Palliative Care in 2019. From then, we started the full-fledged palliative care department. The cancer hospital was, our hospital was started in 1996. And Kannan sir, who has recently been conferred the Padma Shri, is our backbone of the Kachar Cancer Hospital and inspiration, under whom we are working here. And once we get a cancer hospital and once we get a palliative care department, the first foremost function is for successful running of any palliative care unit is the presence to maintain some standard which has been given by the PAL in India with the standard audit tool. And as Rajagopal sir was telling that, one of the essential requirement for any hospital to provide quality palliative care services is an uninterrupted morphine supply and the need or a system for adequate documentation of stage 3 opioid. And a desirable requirement is sufficient access to free morphine to our poor patients who come for cancer treatment. So as far as the procuring of morphine is concerned, definitely we had a very harsh narcotic law and we had lot of problem because I'm also part of this bad processes which went through in 2009, you know.
Val, you're on mute.
Licensing.
Yeah.
Several licensing agency required and we had lot of pain, but as due to the effort of all of our proponents of palliative care, this job has been made so easy after 2014. You know, the cancer patient, you know, their bones and ashes will shower their blessings on the proponents of palliative care who have made this amendment and made available morphine for these patients. And as far as the procurement of morphine is concerned in our state, the job has become much easier. Today I called three of my colleagues. One is Dr. Deka from State Cancer Hospital in Assam. I called Dr. Dinesh Goswami, sir. Dinesh Goswami was the person in 2007. He came here and did an opioid workshop. And only because of him, you know, we applied for narcotic license and we are still using this license. So I want to thank Dr. Dinesh Goswami also for starting this venture in our hospital. Now I have ranked everybody. Now the things are very easy. The NBPS is accepted by the government of Assam. And from what I learned from the Rajagopal lecture just now is that there are two powers now here. One is central power, which regulates the narcotic law, and the regulation are uniform throughout the country. And one is the state government power, that is power for authorizing the medical institution RMIs, and that too by a single state drug controller, unlike many other we used to have earlier. And this has made our job very easier. So this is last year we have procured about 10,000 of injection of morphine, that is 10 milligram per ampoule, and 2 lakhs of instant release morphine containing 10 milligram each. Now, as far as the use of morphine and other essential narcotic drugs are concerned, we do have, apart from the morphine, we do have fentanyl patch in the strength of 25 microgram and 50 microgram, which are very, very essential sometimes if the patient cannot take orally, but definitely they have an added cost. And apart from that, we do have tramadol and as a weak opioid, and we don't have much problem in getting tramadol. And these are the narcotic drugs which we use very commonly in patients who are having severe to moderate pain in our OPD, as well as in the inpatient unit, as well as in the home care patients also. We give all these drugs to mitigate the suffering of the patient. Now, coming to the once we have the drug in our place, it is very, very important to maintain the drug nicely so that the drugs is not being go in the wrong hands. So we have a very good system of maintaining the safety of the drug in our hospital. Each and every consignment after it comes, they are being taken out, they are being counted, they are kept in double locker. And what the Rajagopal sir was mentioning about the chart, that is the opioid morphine register. We have separate register for the intravenous as well as the tablet, and we daily update it as the patient takes away the morphine tablets and injection from us. Now, using morphine definitely has many issues, and we have seen that over my since 2007, I have seen that many people are not compliant with the dose of the drug. They are not happy with taking 4-hourly doses of the drugs. If you write 4-hour prescription, that will take one in the morning, one in the evening. So they said that I am okay with this drug. Probably we are lacking in our assessment, probably because patients are taking the drug. And another problem is that some of the patients do have problem with constipation, which is especially in elderly patients who have motility problems, who are diabetics, who are having already on some constipating agent. I have seen that using morphine in this group of patients, they just say, no, I can't use this. I will not take this tablet in my lifetime. So we do have some tough time, especially in elderly group of patients. Nausea vomiting is also a complaint in many patients. And these are mainly, I have asked my home care team that do you face any problem with morphine use in the peripheries. They said that the patient do complain of nausea and vomiting. And they need to rescue IV metoclopramide injection to mitigate the nausea and vomiting, because oral metoclopramide sometimes does not help. Probably they have some GI problem. I am not clear to that. Another problem is that we have faced opioid patients who are opioid resistant. Like especially I have seen that in patient we have a very huge number of gallbladder cancer patients here. One of the second most common is gallbladder cancer here. And these patients are jaundiced. And I have seen that oral morphine does not work at all. If you give 10 milligram of morphine and patient become drowsy and the patient does not relieve. Whereas if you try with a subcutaneous as well as IV doses of 2 or 3 milligram of morphine, they just do very wonderful. So this is a problem. And also we do experience opioid hyperalgesia in some group of patients. Patient just said that, sir, in front of many patients, they just say that, sir, your medication has increased my pain. So sometimes we get dejected in front of many people, that your drug is not working. Instead, it's giving more pain. Though there are many literature, we have seen that opioid do have some hyperalgesia, but in very minute number of cases. This is about regarding how you our prescribing practices of morphine. And as regards, the acceptability of morphine uses, initially we do faced a lot of resistance from the community, from the patient. I still remember one patient in 2010. He was mother of a doctor, and the patient came in breathlessness, and we have to give low dose of morphine in that patient, and immediately the patient went into drowsiness, and there was hue and cry in the ward, and everybody, doctor came running, sir, so you have given morphine and killed my mother. So we run here and there, and we gave naloxone injection out of, then patient came back and patient was okay. So this was the problem initially, and we have a very good team of doctors here in our hospital, and we have trained our nurses also. It is a regular process. Many nurses come and go, and we have in-house nursing program. So training and retaining nurses is very, very important here. And many of our people from Project Hamrahi, the people from outside Australian Pediatric Care International, many people have come and helped us in achieving our goals.
Thank you very much, Dr. Iqbal.
Thank you very much. Thank you very much.
Can I ask one quick question? Do you ever actually run out of oral opioids?
Hello?
Do you ever run out of oral opioids?
No. Over the last 3 to 4 years, I'm very happy to say that we have never run out of oral morphine. We are getting good supply.
That's fantastic. Well done.
Thank you. Thank you very much.
Yeah, that's a great record. You can be very proud of it. Shall we try once more with poor Dr. Rita? Do you want to see if you can share your screen or just talk to us? Either way, Dr. Rita, whatever works.
Okay, I'll just try sharing once. If not possible, I'll just talk.
Okay.
Okay, then leave. I'll just talk. There is some problem regarding sharing my screen. So I just thought I had made beautiful slides for today to show you all about
Sorry for that, but maybe
yeah,
you can share the slides with us. We can distribute them
sure.
through after. I'm sorry about that.
Yeah.
Okay.
So actually, when I talk, we are talking about opioid availability issues in Bihar. Um, Bihar is the third most populous state of India and 12th largest by territory. And the burden of cancer is very high. It is projected to be around more than 1,36,000 in 2026. So we have started our palliative care OPD. I am working in Mahavir Cancer Sansthan Research Center, Patna, which is one of the premier hospital for treating cancer patients, and I have been working in this hospital since 2005. I joined here as a postgraduate student of radiotherapy, and then currently I am working as a senior consultant, radiation oncologist, and palliative care in charge for my hospital. I think I am fortunate enough to meet Dr. Rajagopal sir and Dr. Audit also, and Shalini also came to our hospital several times, and we had met in 2018 December 2018, when we were having workshop on opioid availability issues only. And I was then also fortunate enough to share my ideas regarding what palliation is, why palliation is important in case of oncology patients. Now, regarding the opioid availability in my state, what there are three centers in Patna. One is IGIMS, Indira Gandhi Institute of Medical Sciences. The other one is AIMS Patna, and the other one is Mahavir Cancer Center, where I work. These are the three places where morphine is available in the pharmacy store. And Bihar has got 38 districts. Out of 38 districts, only 2 districts have availability of opioids. The other district where opioids are available is Muzaffarpur, where which in Muzaffarpur there is a cancer hospital from Tata. They have established it, and opioids are available there. So out of 38 districts, only 2 districts have availability of opioids at the moment. Rest, as Khandelwal sir, he is a very senior oncologist, and probably he introduced me to Dr. Audit. As he was telling, it is a huge problem. We don't have opioids available even in the medical colleges where you are treating cancer patients. So just 3 hospitals where opioids are available. And if we talk about a little bit of history of palliative care in Bihar, as I gathered information, uh, more opioid tablets were available since 2005. In 2005, with help of the World Health Organization, around morphine tablets were available in Indira Gandhi Institute of Medical Sciences, and 2 doctors who took up training, Dr. Rajesh Singh and Dr. B.B. Verma, from Trivandrum, from Rajagopal sir only, for 6 weeks. They took up the training and they were doing palliative care. But the major impetus for palliative care only started when we also had the opportunity to have training under CTC3, Cancer Treating Center program, a joint venture of AIMS New Delhi and APHN, Asia Pacific Hospice Network. So the major impetus came only, I think, in 2018 onwards, when AIMS Patna and IGIMS Patna, a team of doctor and nurses went there for the training. And in 2019 January, we also went. I with one doctor and 2 nurses made a team, and we went to New Delhi for the training. And that is how our journey in palliative care started. Before that, I was doing palliative care in my radiotherapy OPD only, and people were like kind of very ridiculous also. Why doing palliative care when the patient is going to die? What's the use of doing palliative care? Why do you want to leave radiotherapy? Anyways, I have not left working in radiotherapy department, and I am still continuing there and doing palliative care. But after the team, after we build up a team, we got an idea how to start palliative care in a structured manner. Because when I had joined in 2005 in Mahavir Cancer Sansthan, then also morphine tablets were available. But then we didn't know how to use it. And there were times when I used to inquire in my pharmacy whether morphine tablets are available or not. There were so many times that it was not available in the pharmacy. So in that event, we often used to stop writing opioids. But the awareness for writing opioids and how to use, yeah. So it only happened after we took up the training and started doing it in a structured manner. Just hold on a minute. Stop it. So talking about the opioid availability issues, just stop it. Hello, am I audible?
Yes.
Hello.
Yes.
You
Yes,
are
you
audible.
are.
You're audible.
Yes.
My colleague is trying to share the slides, but I just asked them to stop it. I was
Yeah.
just to go on speaking. So there are 4 centers in Bihar out of 38 districts where opioids are available. The opioids which are available are morphine, is immediate release, sustained release, and tramadol and tapentadol. That is all. Methadone was available for some part of time in AIMS Patna, but they didn't use it and it actually expired. And the status of RMI, as far as RMI is concerned, AIMS Patna and IGIMS have the RMI status. My hospital does not have the RMI status. It is still procuring morphine or opioids in the same old pattern. When I tried to get the RMI status of my hospital, my pharmacy people were very reluctant. Why do that, madam? What's the problem? We are having uninterrupted supply of morphine. And by the time I have started, I have been taken the charge of palliative care, and supply of opioids has been uninterrupted. But still I feel that you need to be kind of updated, and you need to have an RMI status. For that I have been talking with my director, and it is it may take shape in near future. And as far as the how the colleagues feel and what are the ranges which we generally use, I did a study also when I was supposed to do this presentation. I saw that I checked my register, how many patients need what doses and what strength of morphine, and I found that majority, 80% of the patients do fairly well till 120 milligram of morphine, ranging from 20 milligram to 120 milligram of morphine. Only less than 20% of the patients need more than that, maybe 150 milligram or 180 milligram in a 24-hour dose. And as far as the situation is concerned, how my colleagues think about prescribing morphine, as I heard from people and doctors from other part of the country, the story is same. Either even when you prescribe doses in the morphine in the adequate doses, there are people, there are nurses, there are healthcare staff, there are doctors, there are medical officers who on and off tell people that, oh my god, you are taking doses in such a high dose, what will happen in future, stop taking it. For example, today only a 16-year-old boy who is a case of CA rectum, and he was being treated under me for radiotherapy, and I had prescribed him morphine for pain control. He is doing fairly well. He completed his radiotherapy. He underwent surgery. At that time also, he was on morphine for pain control. Everything was fine. Today he turned up and he told me he again came in pain after 3 cycles of adjuvant chemo. And today he is telling ki, ma'am, I'm in pain. I asked him, where were you? Like he said, I was fine, ma'am, but that sister told, why taking so much doses of morphine, what will happen in future? So I stopped taking it and I've shifted to tramadol. So this is a real life situation which happens every time. And recently, like as I learned how to do more of, kind of documentation, proper prescription writing. In fact, I remember discussing this problem with Rajagopal sir in IGIMS regarding what do you initiate first, paracetamol or morphine? What is more important for the patient? So as I build up on my experience and as I have learned, and in that this process, we also learned the importance of team building. So many doctors, also like-minded doctors, especially my friend Dr. Mukul Mishra, who is a family physician and who is also in this meeting. She is also there in the meeting, and she joined hands with us, and we are offering palliative care services to our patients. But our colleagues are still like, okay, if nothing can be done, if no cancer-directed treatment can be done, then only send to palliative care OPD, or else keep on treating, and send sometimes for pain control. If you prescribe something, then they have their own preset notions regarding opioids. They have opiophobia regarding, and several times we have taken sessions. Few of them change, but many are still very reluctant using opioids. So this is the problem, but nevertheless we have kept working, and things have improved, and people have started kind of trusting us for, and have started sending our patients to our OPD. And when Dr. Audit has visited our hospital, we didn't have a dedicated palliative care OPD, right? But now we have a palliative care OPD, we have a 14-bedded IPD, and even because Dr. Mukul Mishra is a family physician by training, we have started an emergency palliative care where we have our system to help the patient who come in respiratory distress or severe pain, where we start titrating the doses of IV morphine, and then channelize things. So things have improved, but there are many milestones to achieve. And apart from that, we had a meeting in 2019 regarding kind of starting palliative care, make a palliative care policy of Bihar. Fortunately, I was also in that meeting, but it didn't take shape because of the COVID issues. But recently again, some people called me that they want to initiate, at the least initiate, the availability of morphine in the palliative care services, start with a pilot project in 6 of the districts. I don't know, it might take shape in near future, and I'm very hopeful for that. And sometimes I feel very bad, Bihar being a very populous state, third populous state of India, and palliative care services available only in 4 centers. There are doctors, there are oncologists who are private practitioners and who are referring patients for opioids in our hospital or in AIMS Patna. And with this, I think I will end my discussion, and I'll ask Dr. Mukul Mishra also to share her views.
Thank you so much, Dr. Rita. We're running almost out of time. So we may, Dr. Mishra, if you wanted to say 1 or 2 words only, but there's a lot of noise, I'm afraid. I think there's too much interference. Oh, that's better. Sorry. Unfortunately, I think we've run out of time anyway. So if you want to share something perhaps in the chat while we just kind of wrap up the session. But thank you, Dr. Rita, for, I think many, you can see in the chat, we're all very inspired actually by what you shared. And the courage that you have shown in just persevering come what may. It's fantastic to hear the progress. Dr. Raj, would you like to say a final few words? Just unfortunately, we have run out of time, so we can't have too much more discussion, but I think people would love to hear from you.
No, I was only hoping that another 2 or 3 years from now, we will hear more from Dr. Rita.
Yes.
Almost every pioneer here in every place would have gone through this journey. The initial trouble, the fights, it's not easy. It's not easy for any pioneer. After some time, things get easy. But Dr. Rita and everybody with courage and determination, you have moved forward. People are discouraging you. That makes your success all the more sweeter. I don't have anything else to say about it. I have great admiration for this group. Thank you. And Odette and the team, thank you for what Hamrahi does for this country.
It's wonderful to work with you on this and all your team, Shri and Shalini and everybody. I don't know, I think I've learned a lot from the session, and I really appreciated hearing from each of you, and maybe we can do a similar session again down the track, because sharing all those experiences is really helpful. Brings it right down to the realities of what you're all trying to achieve. So we've got some commitments that, you know, those who don't have more RMI status, or what was it, or opioid availability, will do so by May 22, and that the APLI in India team are ready and waiting to support you and help you. I've got another note, follow up Bihar, Dr. Rajendra, that's right, to work with Dr. Kandawal and maybe Dr. Rita, and see if there's some further support that you can offer. In the meantime, we've got the feedback form that is being put into the chat. We'd be really grateful for your comments. And we have a comment from Dr. Mishra. Thank you. Opioid availability is not the issue. Here it's appropriate and adequate dosing and dispensing of opioids. Okay. So Shri, did you want to say anything finally? Or
I think today we had a wonderful session. Like we all learned a lot from each other actually. So yeah, thank you so much everyone for bringing in the presentation and sharing about your states. Thank you so much, all the faculty from Australia.
Thank you, Shri. And should we just mention the next session is on the 8th of March. I should possibly mention that the Indian Palliative Care Conference is on in a few days' time, which we might meet you again on that virtually. And then the next Hamrahi Echo session is on the 8th of March, and it's a focus on nursing issues. So we have, we'll try and circulate the program to you soon, but we'll be looking at, we'll be asking a number of nurses in our group to present, and probably looking at issues of falls, delirium, the management of delirium from a nursing perspective, and possibly the management of wounds, but we'll let you know. So thank you all very much for our speakers especially, and everybody for participating. Thank you.